from the endocardium to the epicardial area, and you have multiple vectors happening in IVS. However, the dominant vector is from the left side to the right side. And hence, you see this Q waves as negative waves dominant in the leads V5, V6, where they are always present in a normal heart, and they might also be present in leads 1, 2, 3 and AVF. And as we know that lead V1, it should be absent because we have here the dominant vector from the left to the right. So remember, a Q wave in a normal heart should be always absent in V1 and should always be present in V5 and V6. Now, the normal amplitude of the Q wave is usually less than 5 millimeters, but in children it could be a little more than 5 millimeters, and the maximum duration acceptable is 0.02 seconds. You all know that the smallest square is 0.04 seconds, so the Q wave width should not be more than half of the small square. So this understanding is important for us for further understanding what is an abnormal Q wave. So Q waves can be abnormal in two ways. One is that the presence of Q waves is not there in V5, V6, or you see the Q waves in V1, or the Q waves are deeper, or the Q waves are deep and wide. So remember that if Q waves are not present in V5, V6, then what can it be? That means that your interventricular septum location is not normal. So this can happen if my right ventricle is on the left side and left ventricle is on right side, which we name it as L-looped ventricles. That means the ventricles are reversed. Or I do not have a significant interventricular septum. That means I am dealing with a single ventricle. Or I have mirror image dextrocardia. That means all the organs are the other way. My right atrium is on the left side, my right ventricle is on the left side. In such a situation, you will not see Q waves in V6. So in an indirect way, when I see Q waves in V6, I am understanding that my left ventricle is on the left side. I might also see additionally Q waves in V1. So these are the few situations where I would think that my heart is not normal. If I have deep Q waves, normal Q waves should be less than 5 millimeters. If I have deep Q waves, it predominantly means that I am dealing with left ventricular hypertrophy, more related to volume overload. And if I have wide Q waves along with deep Q waves, then it indicates that I have myocardial ischemia or infarction. So there is a little difference between having deep Q waves versus having deep and wide Q waves. So this is the small little Q waves importance. Now coming down to the next wave, which is the T wave. So the T wave represents ventricular repolarization. So as we all understood, the ventricular depolarization is the QRS and the ventricular repolarization is the T wave. And always the T wave will be in the same direction as the QRS. If I have an upright QRS, I have an upright T wave. The T wave amplitude, interestingly, is higher in V5 compared to V6 in a normal heart. Okay, is it audible now? Is it audible now? I hope it is audible now. Amrita, can you just clarify with Palakkad group? Can they hear now? Can they hear now? So the T wave amplitude is more in V5 compared to V6. Palakkad group, can you hear me now? Can you hear me now? Hello? Amrita, is it audible? Can you hear me now? Hello?
Ma'am, can you hear me?
Now it's okay? Now I can hear you. You can hear me? Is
Yeah,
it
okay,
audible?
ma'am. Okay. Now, okay, ma'am.
Okay, so we'll continue now. So the
Thank
T
you.
waves are interestingly seen a little larger in lead V5 compared to V6. And the another interesting thing is the T waves, they gradually increase in its amplitude till adolescence. So they go from 11 to 14 millimeters. So remember that you can have significantly sizable T waves and they could be still normal in amplitude. Now, normally the T wave is upright. Can anyone tell me what is this T wave? This is an upright T wave. What is this T wave? How will you name this T wave as? This is an upright T wave. How will you name this T wave as? Anyone? You can enter your answers in the chat box. This is, how will you define this T wave as? This is an inverted T wave. Yes. How will you define the next T wave? This is a tall T wave or a peaked tall T wave. How will you define this T wave? Yes, so it's a diphasic T wave, and you can see here sometimes you can have a positive and a negative or a negative and a positive. Both are diphasic T waves. And the last one, yes, so this is a flat T wave. So T wave morphologies can vary. Normally it is an upright T wave in the same direction of Qrs complex, and also it can have an amplitude which is approximately 10 to 15 millimeters, more in V5 than in V6, and gradually increases till adolescent age. So now with this understanding, let us see what all abnormalities you can have with T waves. So the T waves can be tall or the T waves can be flat. Typically, tall T waves are seen when? So hyperkalemia is a common situation where we see tall T waves, and the second is where you see is in left ventricular hypertrophy. On the opposite side, you have flat T waves where you have hypokalemia, and also situations where you have repolarization abnormalities, which are typically seen in pericardial disease, myocardial disease, or digitalis effect. So these are the situations where you see repolarization abnormalities, and hypothyroidism where overall your complexes are low. You also have flat T waves. So this is about the T wave. Now coming to the important segment which is related to the ventricular activity, which is the ST segment. Now the ST segment occurs after the S wave and before the T wave, and hence it occurs after the ventricular depolarization but before the ventricular repolarization, and it is always isoelectric. How do you define isoelectric? Isoelectric means it's at the same level as the PQ segment and it's at the same level as the TP segment. This is the TP segment. So ST segment is always isoelectric. However, a minimal variation is acceptable and it's considered normal. How much is acceptable? Any elevation or depression of ST segment of more than 1 millimeter in the limb leads. So in the limb leads, only 1 millimeter is allowed. However, in the precordial leads, up to 2 millimeters is considered to be normal. Anything more than this is not acceptable. And again, that goes in favor of repolarization abnormalities. So normally, if the ST segment is supposedly isoelectric, what is this then? So abnormal ST segments can be like this. What is this then? How will you understand this ST segment? This is the QRS and this is the T. So this is, anyone, you can enter your answers in the chat box. This is elevation. So this is ST elevation. This one, the second figure, yes. So this is depressed ST segment. This one, it's a little unusual. You can see here what's happening. There's hardly any ST segment. So how will you define this as? This is the S and this is the T. Yes, so you will say instead of narrow, you will say a short ST segment. And how will you define this as? A long ST segment. So now let us see just in short. See the abnormalities which we are going through, we are not going to go into the detail because then every single situation on its own we can discuss later on. This just to have a gross understanding about what all can go abnormal in a particular situation. So ST segment abnormalities could be either in terms of elevation or depression. And this is all going to be a separate section in itself where it can happen in pericardial disease or myocardial disease. It can happen in myocardial ischemia or infarction. It can happen in electrolyte imbalances or ventricular hypertrophy with strain, digitalis effects. So these are the common situations where you can see ST elevation or ST depression. Now coming down to the QT interval. So what we saw today is the Q wave, we saw the T wave, we saw the ST segment, and now we come down to the QT interval. QT interval, as a pediatrician, we commonly use this understanding in our practice, and the beginning of the Qrs complex to the end of the T is defined as the QT interval. So here we can see it includes the Qrs complex, it includes the ST segment, and it includes the T wave. So it's a combination of ventricular depolarization with repolarization. It's a combined activity. This is the single interval in the ECG which defines the whole ventricular activity. And we know that the Q waves are best seen in lead V5, V6, 1 and 2, and hence the QT interval is best measured in lead V5, V6, 1, 2 and lead AVL. Now QT interval is a little different compared to PR interval. If you remember, the last class we discussed that the PR interval changes with age and the heart rate both. Now in contrast to the PR interval, the QT interval does not change with age, but it changes with the heart rate. How does it change with the heart rate? It shortens with tachycardia. Shortens with tachycardia means if the RR interval reduces, the QT interval reduces. It lengthens with bradycardia. If the RR interval increases, then the QT interval also increases. And hence, it was formulated that you need to correct your QT interval for the heart rate. And that's where the Bassett's formula came up. So QTC, which is the corrected QT interval, is QT interval divided by square root of RR interval. And the normal QT corrected is usually in the range of 0.35 seconds to 0.43 seconds. And it should not generally exceed 0.44 seconds, except in infants you could see a corrected QT of up to 0.46 or 0.47. Now, just to have a very short way of calculating QTC, if you see an ECG and if you see the heart rate between 60 and 100, then generally QT should not exceed half of RR interval. This is a very quicker way. You cannot use this for heart rates which are exceeding 100, which commonly happens in children. So if it's very fast heart rate like 120, 130 per minute, then your QT could be more than half of RR and it still could be normal. Now with this understanding, what could be abnormal QT? Abnormal QT could be either the corrected QT is prolonged or the corrected QT is shortened. Yes, we can have a short QTC also. QTC is prolonged typically in hypocalcemia or certain drugs like quinidine, or it can happen in situations where you have syndromes like JLN syndrome or Romano-Ward syndrome. It can happen in myocarditis, heart block, or hypertrophic cardiomyopathy. Whereas short QTC happens when? In hypercalcemia with digitalis. So this is one very important effect of digitalis. We will see some time later in the class that digitalis can cause shortened QTC. There are very few causes for short QTC. So these are the situations where QTC can be abnormal. Just to summarize, QT interval is very important for us because it gives an understanding of the whole ventricular activity. It does not change with age, but it changes with the heart rate. Generally, it does not exceed 0.43 seconds, but in infants, you can accept it till 0.47 or 0.48 seconds. Now, we are just ending the understanding of the individual waves, and the last wave is the U wave. Not much importance, except you need to understand that this U wave can be seen in abnormal situations like hypokalemia, or it could be normally present. And when you are trying to calculate your QTC, make sure that you don't include the U wave. It's a small positive wave in the same direction as T wave. So the T and the QRS and the U, all of them are in the same direction. We're just going to summarize now in this slide what all we understood. This is the P wave, this is the QRS, and this is the T wave. So the PR interval is from the beginning of the P to the beginning of the Q. The RR interval is from one R to another R, and the QT interval is from the beginning of Q to the end of T. We have two segments, the PQ segment, the end of P and the beginning of Q is the PQ segment, and the ST segment is the end of S and the beginning of T. This is in seconds, this is in millivolts. Now we come down to the last slide of this basics, which is on the rotation of the heart. Now the rotation of the heart is actually a little more confusing, and hence, we'll try to simplify and understand. Commonly, whenever you go to individual heart disease, they would say that it is clockwise rotated, it's counterclockwise rotated, and it's always confusing to imagine what happens based on the ECG being seen in front of us. So now, the rotation of the heart is understood in two planes. One is in the frontal plane. So now imagine this frontal plane, which is the coronal plane, and the second is in the axial plane. Now this is the coronal plane, and imagine the heart which is in this position. You have your line which is passing through the interventricular septum around the anteroposterior axis. So imagine a line which is crossing from the anterior to the posterior aspect of the thoracic cavity. So your frontal plane, you can imagine your frontal plane, which is like this. The frontal plane is like this, and your axis is like this, anteroposteriorly. And your axis is from anterior to posterior across the frontal plane. So imagine this heart, which is rotated like this. The heart rotates like this, like this. So if your heart is more vertical, you have an inferior axis, and if your heart is more horizontal, you have a more leftward axis. So this is what you see. If you have a horizontal heart, the axis is more leftward, versus if you have a vertical heart, you have more inferior QRS axis. If your heart is rotated in this direction, you will call it as counterclockwise looping, and if you have it this direction, you call it as clockwise looping. Now remember, the word clockwise and counterclockwise is used for both the frontal plane and also the axial plane. However, in the axial plane, it has much more implications than the frontal plane. So coming from the anteroposterior axis in the frontal plane, we come down to the next plane, which is the horizontal plane or the axial plane. So imagine this is an axial plane, this is anterior, this is posterior, and your rotation happens across a vertical line. So you are actually viewing the heart from below, from towards the leg point. You have a cut section of the heart like this, and your axis is running like this, like this. So you have the cut section, you're visualizing from the foot end towards the head of the patient. And so the heart is like this, and you see the right on the right side and the left on the left side. Now in this view, this is anterior, this is posterior, and you see this leads which are kept on the chest from V1 to V6. Now in this, when the rotation happens, imagine if the rotation happens like this, it is called as counterclockwise. This is counterclockwise rotation. And if it's counterclockwise rotation, you can imagine that left ventricle comes to lie more anteriorly, and your transition will happen early. Your transition will happen in V1, V2 instead of V3, V4. Compared to that, if you have a rotation which is happening like this, in this direction, this is called clockwise rotation, where your RV will come to lie more anteriorly, and hence your transition is going to happen later. I know it's a little confusing. We can go through it once again. Remember, your rotation happens in two planes. One is the frontal plane and second is the axial plane. When you imagine the frontal plane, it is the coronal plane, and the rotation is happening across the anteroposterior axis. It's like this. It's across the anteroposterior axis. And this rotation, the heart rotates like this, like this. So if you have a vertical heart, you have a lower inferior QRS axis. If you have a horizontal heart, you have a more horizontal leftward QRS axis. Compared to that, if you have rotation which is happening in the horizontal plane or the axial plane, imagine you are looking from the foot end towards the heart. This is anterior, this is posterior, this is right, V1, this is left, V6. And if you have a rotation which is happening counterclockwise, you have LV lying more anteriorly and the transition happens early. Whereas if you have clockwise rotation, you have RV more anteriorly and you have a late transition. So if you are seeing your precordial leads, you have an early transition, it goes more in favor of counterclockwise rotation. You have a late transition, you have a clockwise rotation. Remember, last class we discussed about the transition. Transition means your RS ratio is 1, which commonly happens in V3, sometimes in V4. If it's early transition, that means it's happening in V1, V2. If it's late transition, it's happening in V5, V6. Early transition commonly happens when your LV is more anterior. Late transition commonly happens when RV is more anterior. Just a very easy way to remember: clock, late transition. This is how I remember it, to just memorize it. Clockwise rotation is late transition, counterclockwise is early transition. Now I hope it is clear, and if you have any doubts at the end of the class, you could tell me. We could go through it once again. So this is the end of the basics of ECG, and now we are going to go to the second most important understanding, which is the electrical axis. Now, electrical axis is considered for the QRS complex, the P wave and the T wave, all three individually. But the principles are going to be the same. So we will start with the understanding of QRS axis. Before we go into the axis, there is a little correlation between the hypertrophy of the ventricles and the axis. So now let's see how age can make a difference, because we all look at children ranging from day 1 to 15 years or 18 years old. Now, how is it different? The left ventricle and the right ventricle weight ratio is different. It's different at birth and it's different in an adult. In a newborn, the right ventricle weighs more than the left with a ratio of 1:0.8, whereas in an adult, the left ventricle weighs more than the right ventricle, up to 2.5:1. This RV dominance of an infant gradually changes to LV dominance in an adult with a little variation at different ages, and along with that the QRS axis also changes. In a newborn it's rightward and anterior, and in an adult it is left and posterior. So as you see, the heart is a little more vertical and then the heart becomes a little more horizontal. Now this understanding, in between the 1 month to 3 years, you can have an ECG which is in between. So let's see what we can understand for the QRS axis. A little revision of what we saw in the last class. The activation of the ventricles is happening at multiple points in a synchronous way, with multiple vectors happening from the endocardial surface to the epicardial surface. However, at the end of it, what we see is the net vector, and the most dominant net vector direction is expressed as the QRS axis. And here also you know that initially you have the left to right vector in the interventricular septum dominant, and after that you have the right to left vector in the free wall. So you have to graph the QRS axis on the basis of the 6 frontal plane leads. Is the QRS axis always calculated only in the frontal plane? Not really. You also do it in the precaudal leads, but a predominant understanding happens in the frontal plane. So what we are now going to see is calculation of the QRS axis in the frontal plane leads. Now, as we know this, we have this frontal plane and it's termed as the hex-axial reference system. Why hex-axial? Because you have 6 leads. And we know that this is the lead 1, this is the lead 2, this is the lead 3. This is AVR, this is AVL, and this is AVF. And we have given them some degrees. Remember that these degrees have nothing to do with the positive and negative poles of the leads which we discussed in the last class. So empirically we started with 0 degrees for lead 1, and then we kept going in a clockwise direction to plus 180 degrees and in an anti-clockwise direction to minus 180 degrees. So this is how we would name them as. Lead 1 is 0 degrees, and then lead 2 became 60 degrees, AVF became plus 90 degrees, lead 3 became plus 120, AVR became minus 150 degrees, and AVL became minus 30 degrees. So in short, you can see here, your leads range from minus 30 to 120, except the AVR lead. And it's very interesting. It's almost like maths here, if you can see that lead 1 has 0 degrees here. That means that it has a positive polarity here and a negative polarity here. So if I try to put it in a semicircle, the positive segment is here and the negative segment for lead 1 is here. Similarly, if I try to put it for AVF, because it's directed here at 90 degrees, the positive segment is going to be the lower half and the negative segment is going to be the upper half. And if I try to put it for lead 2, because lead 2 is directed towards 60 degrees, then the positive polarity is this half and the negative polarity is the other half. Now here you can see another interesting point. Lead 1 and AVF are exactly perpendicular. Similarly, lead 2 and AVL are perpendicular and lead 3 and AVF are also perpendicular. So you have pairs of leads which are perpendicular to each other, and this is going to be helping us to make understanding of axis more easy. Now, how do I calculate the axis? The Qrs complex in your frontal lead has an amplitude in terms of millivolts. So, if you have a positive and a negative amplitude, you need to find the net amplitude by subtracting the negative deflection from the positive deflection. Second is, a vector is parallel to the lead where it has the maximum positive deflection. For example, if my lead 1 has the maximum QRS, then my vector is going to be parallel to lead 1. And the vector is perpendicular to the lead where there is an equiphasic deflection. Equiphasic means I have the same R and the same S in 1. Then it's going to be perpendicular to 1. That means it's going to be in this direction. That's called an equiphasic deflection. So let's see an example here. If I have, for example, if I have a lead 1, 10 is the R and 3 is the S wave. So what I will do is, I will plot here a line at 7 in lead 1 because it's 10 minus 3. And in AVF, I have the QRS, which is R is 8 and S is 2. So my net deflection is 6. So I plot it at 6 here. See the small squares. And then I draw the line from the points 7 and 6, which meets here. So this is the junction and I draw an imaginary line here. So this is going to be my axis, the Qrs axis. So just to summarize once again, I can use lead 1 and AVF, pick up my QRS net deflection, draw a line here, pick up my AVF vector, and then the junction of both the points, I draw an imaginary line, and that is going to be my axis. For example, here, it's between 60 and 30 degrees, so it's going to be around 45 degrees. Just see here once again. If my lead AVF has a positive deflection or my lead AVF has a negative deflection, then my QRS mean vector is going to be like this. If it's positive, it's going to be towards the positive. If it's negative, it's going to be negative in AVF. If I have a little positive or a little more negative, then it's going to be in this direction, positive, negative. And if I have a null deflection, that means almost no voltage or a small equiphasic, then it's going to be perpendicular to lead AVF. So then how do I proceed? The easiest way first is to locate my quadrant of Qrs complex. Quadrant means if I have my Qrs in lead 1, which is positive, and AVF also positive, then I know that my Qrs axis will be in left lower quadrant. If I have my lead 1 positive but AVF negative, then it is in left upper quadrant. If I have my lead 1 negative but AVF positive, it's in right lower quadrant. And if I have my 1 and AVF both negative, then it's in the right upper quadrant. You could use similarly any two leads. It could be lead 2 and AVL. It could be lead 3 and AVR. To first locate your quadrants. But I feel lead 1 and AVF is much easier to understand. So once you locate your quadrant, then after that you see which lead has an equiphasic QRS complex. If you have the same R and the S voltage, then you know that the QRS is going to be perpendicular to that lead. For example, in lead 1, if I have equiphasic QRS, then I know that it's going to be perpendicular to that. That means in the direction of AVF. And once I have already located the quadrant, I know that whether it's going to be down or up. The third point would be then to go to see which lead has the maximum QRS deflection, either positive or negative. And then I know that it's going to be close to that lead. So these are the 3 steps to understand the QRS axis. Now, sometimes what it can happen is that you can have equiphasic QRS complexes in most of the leads. Then it gets confusing because most of the leads is equiphasic, then where should you go? In that situation, you have to calculate 2 parts of QRS axis, which is called the initial and the terminal, which is separate. I do not want to confuse further, so we will not go into that detail. Normal QRS complex is how much? The normal QRS axis is between 0 and 90 degrees. However, if the baby is small, it can be up to 140 degrees. That means a little right axis deviation is acceptable for a newborn. And between 3 months to adolescent, you can have it going up to 120 degrees. The right lower quadrant is considered generally for an adult to be a right axis deviation. The left upper quadrant is considered to be a left axis deviation, where it can be slight or marked, and the right upper quadrant is considered to be a north-west axis. So this terminology is important for us. We consider right axis deviation, left axis deviation, or north-west axis. And the left axis deviation is commonly seen in children who have left ventricular hypertrophy or an accessory pathway or a bundle branch block. You have right axis deviation commonly in certain congenital heart diseases with right ventricular hypertrophy or with accessory pathways or with bundle branch blocks. Now, similarly as QRS complex, QRS axis, we also can calculate the P wave axis. And is it important? Yes, because the direction of atrial depolarization gives you an understanding where your pacemaker sits. So normally our pacemaker is the sinus node, and hence the P wave axis is usually inferiorly and leftward. It is usually 40 to 60 degrees, and if you see it in the axial plane, it's anterior. These two things we had done it in the last class, the direction of P wave vector. So that is what decides the P wave axis. Now there are certain congenital heart diseases where your P wave axis changes. If it's left axis deviation, it is usually less than 40 degrees. And if it's right axis deviation, it's more than 70 degrees. What if my P wave axis is less than 0 degrees? That means my sinus node is not working and my pacemaker is from the lower part of the atria and it's going up. What happens if my right atrium is on the left side? Then my axis is going to be down and right, where my P wave axis is going to be plus 120 degrees instead of 40 degrees. Similarly, we calculate the T wave axis. The T wave axis represents the mean vector of ventricular repolarization, and like QRS, it is between 0 and 90 degrees. Normally, the T wave axis and the QRS axis is in the same direction. However, for a younger baby, there is a little difference. The T wave is usually upright for the first 3 days of life. This is a very important understanding. From the 4th day, it becomes negative and it stays negative for the first few years of age, maximum up to 8 years of age, and then progressively becomes upright. So a negative T wave between 3 days to 3 to 8 years of life is normal. The T wave axis, if it is abnormal for age, it means that we have ventricular hypertrophy or a myopericardial disease. The T wave axis moves away from the region of pathology. That means if I have myocardial infarction, the T wave will go away from the place where there is ischemia or infarction. So this is an important understanding because it gives me a clue where my problem lies. So T wave always moves away from the region of pathology. You will see this is so different than the ST axis. There is something called QRST angle. So you find the QRS axis, you find the T axis, and then you find the angle between the QRS and the T axis. As we know, the QRS and the T wave move together, and hence you should not have your QRST angle more than 60 degrees. If it is wider, then it is abnormal and it indicates some issues with ventricular depolarization and repolarization. But remember that the wide QRST angle is less significant if your T axis is normal. So your T wave axis abnormal with your wide QRST angle is more suggestive of a pathological situation. You can have a wide QRST angle in situations where you have ventricular hypertrophy with strain or in myocardial dysfunction. Now coming to the last axis understanding, which is the ST segment axis. The ST segment axis is important for us because it moves towards the surface of injury in contrast to the T wave axis. For example, in pericarditis, which is acute, typically the apex gets affected. And there you will see the ST segment in this direction because it moves towards the apex. That means your ST segment axis will be around 30-40 degrees. Now, generally we calculate the QRS PT axis in the frontal plane. However, we also need to calculate in the horizontal plane. Why is it like that? Because the frontal plane gives you an understanding about superior, inferior, right, left. But the axial plane gives you an understanding about the anterior and posterior relationship apart from the right and left. And hence, to understand that anterior-posterior relationship, we need to calculate it in the horizontal system also. And we know that we have 6 leads in the horizontal system. V1 to the V6 and the angle between the 2 leads is supposedly 30 degrees. And between V2 and V6 it is approximately 90 degrees. So here if you see, your V6 is leftmost and your V2 is anterior most. So just as we used our leads 1 in AVF, we can use the leads V2 and V6 to have an understanding about anterior, posterior, right and left. For example, if it's positive in V2, I know it is anterior axis. And if it's negative in V2, I know it is posterior axis. We can define these segments for polarity in a similar way. For example, in V2, the front half is positive and the back half is negative. Whereas in V6, the left word is positive, right word is negative. And in V1, we have to cut it like this because V1 is directed like this. And this is positive, this is negative. So to incorporate this anteroposterior relationship of the horizontal system, in general, they have advocated to use an arrow like this. So in V2, if I have my V2 like this, I'm supposed to be putting the QRS vector like this. If it's negative, I'm supposed to be putting it posteriorly like this. And if it's intermediate, that means I have an equiphasic V2, I'm supposed to be put it like this. But in practice, we do not do it. This is just a summary of what we spoke about the QRS, where you can have an axis up to 180 degrees in a newborn, tall R waves in V1 in a newborn, RS ratio of more than 1 in V1 in a newborn, and that the T wave can be upright for the first 3 days. It does not suggest RVH. Okay, just for all of you to go through this, just for a revision, I think we can do this. Can all of you calculate the QRS and the P wave axis in this ECG? So you have this ECG here where you have a 12 lead. Can you calculate the QRS axis and the P wave axis here and write your answers in the chat box? So you need to go systematically. First, find out which quadrant the QRS axis is. Anybody wants to? Yes, so the QRS axis is the left lower quadrant because it's positive in 1 and positive in AVF. Now we go to the next thing. Do you find an equiphasic QRS anywhere? Or a null QRS anywhere? No. I'm not sure if we would consider this because the forces are almost not there in AVL, but we will keep this in mind. This is around minus 30 degrees. So a lead which is exactly perpendicular to this would be around plus 60. If I consider that I have a null vector here, then perpendicular this is going to be plus 60, but anyway I'm not sure. So then I go to the next understanding, which lead has the maximum positive or negative deflection. Okay, now we are calculating the frontal one. We are not calculating the chest leads. So can we see it here? amongst the standard leads and the unipolar leads from the frontal plane, which is the lead which has the maximum positive deflection. Is it lead 2? Yes. So lead 2 is plus 60 degrees. So my axis is going to be very close to plus 60 degrees by all three criteria. And can we calculate the P wave axis in a similar way? My P is positive in 1, positive in AVF, and hence it's in left lower quadrant. I have no place where it's equiphasic, but you can see here the lead 3. It has a small negative deflection, so it could be exactly perpendicular. So if my lead 3 is here, exactly perpendicular is here, so it's going to be plus 30 degrees, and my lead 2 is also positive, so it's around 30 degrees. So this is how you would calculate your QRS and P wave axis. I hope it's clear. Any more questions from anybody? I think we are done with the basics of ECG. If anybody has any questions.
Any questions or clarifications? Any questions?
Can you please explain the rotation once more?
Any questions, please? Any questions, please? Rotation once more. Okay. Now see this, Amrita, there is a lot of echo coming. I think somebody else's speaker is on. Okay, so this is the rotation. The rotation is done in two planes. This is the frontal plane. Just a minute. This is the frontal plane, and in the frontal plane, imagine yourself, and this is the coronal plane. The coronal plane, the line passes across the IVS from the anterior to the posterior direction. So this is the whole cardiac mass, and this rotation happens in across this angle. So if this is the patient, the rotation happens like this in this plane, and the line passes across from anterior to posterior direction. So this heart mass is rotating like this, like this. If it's rotating in a clockwise direction, this is the clockwise direction, and this is the anti-clockwise direction. If it's the clockwise direction, the heart comes to lie a little more vertical and the QRS axis is inferior. Whereas if it is in the anti-clockwise direction, Then the heart lies more horizontal and it's a left QRS axis. Whereas if you see in the axial plane, the line passes across the center of IBS, and here it is from, see, this is the cross section and you're viewing from the leg side towards the heart. This is the line which passes from superior inferior aspect of the heart, and this is anterior, this is posterior. So this is the cardiac mass, and if it rotates in a counterclockwise direction, that means that the LV comes to lie more anteriorly in a clockwise direction, and I will see my transition in the precaudal leads early. Whereas if it's clockwise rotation, then my RV comes to lie more anteriorly, and this is a transition happening close to V6. I think you need to pay a little more attention to this part. The frontal plane is easy to understand. The horizontal plane, remember yourself seeing from the foot end towards the patient's heart. And imagine this cardiac mass. The rotation can happen in this direction or can happen in this direction. So this is counterclockwise, this is clockwise. In counterclockwise, LV is more anterior. In clockwise, RV is more anterior. I hope it is a little more clearer. Maybe you could read it once, and the next session we can relook at it if you still have some doubts. Anybody, any other question anybody has, or we can end our session today, Amrita?
Yes, ma'am. I think we can wind up now.
Yeah. Thank you so much.
Thank you for the excellent class.
All of you have a nice day. See you sometime next month.
Thank you.
Bye.
Bye.